Good evening, everybody. It's a difficult task to speak after Dr. Fatima Begum, who is a good friend of mine for past 30 years. But anyway, she has made my job easy. Now I'm going to speak about echocardiographic evaluation of pre and post procedure ASD and VSD. Among all the various types, you know that only ostium secundum and sometimes rarely sinus venosus type can be closed with the device. And for this, it is very important for the interventionalist to assess the various atrial septal rims as well as the structure and the size and the shape of the ASD. And this is possible only when we understand the whole how to do the echo. In fact, among the thousands of ASD device closures I have done, I have never had any complication either as arrhythmia or oversizing or perforation, none of those things. That is because of the proper assessment. So the deficient rim, central defects, deficient posterior rim, all these things can be made out. The best view is the subcostal view, where you get the longest length of the intraatrial septum. And this is very important because any device has got to, you have to add 7, that is 14 millimeter extra. So here, this is the intraatrial septum can be measured. This is not the right view because the aorta is coming and that should not happen. And whenever you are taking, this is the subcostal bicaval view. And this is very important for any echocardiographer. It almost mimics like your transesophageal echo. And this is the view where you get the superior rim, inferior rim, and whether it is the flimsy or aneurysm, all that can be made out very well in this. And apart from that, you have to not only measure the ASD size in one view, at least 2 to 3 views we have to measure. You have to measure the ASD size, the superior, inferior rim, and the whole of the intraatrial septum. And especially when there is a sinus venosus type of ASD, that can be ruled out for the device closure. And hence the aortic rim is very important. Many a times, the device closures, the people oversize and they get into erosion, either immediate or at a later stage. But what is important is echo can measure the length, but not the strength of the intraatrial septum. And that, it may start wobbling sometimes, but you don't have to be worried. And in this direction, 3D, 4D echo have come very handy. We can know the shape and the size and the measurement. And here, even if we oversize in the oval type of the ASD, you can have a residual shunt like this, in spite of having a proper size. And that is because the shape is oval. I'm sorry, this is not moving, but in the 4D echo, you can see it from the RA side or the LA side. And as a result, you get a very good view. And oversizing can be avoided when you take the 4D echo from both the sides. And here you can see that in the 2D echo, it appears that the inferior rim is impinging or bulging to the LA side. But when you look at the 4D echo, the intraatrial septum is very much into the thing. And in the past, we were giving aspirin or clopidogrel empirically for 3 months, 6 months, depending on the big size. Now, no more. See, this is the histopathology in the animal, and this is in the 4D echo. You can see how much endothelium has grown, and then you can stop the aspirin. And not only you can see from the RA side, the LA side, and you can see that whether there is any thrombus or anything. And especially when there is a fenestrated one, whether to make it into one or you have to put two, sandwich the two devices, all these things can be made out by the echo. And when the rims are inadequate or when there is a fenestrated, you have to be very careful and measure the in-between. And apart from that, when we go to the VSD, this is the 4D echo where we measured about 12 millimeters of ventricular septal rupture. And then I decided to use the 16 millimeter. But had I used the 16 millimeter without doing the 4D echo, the device would have embolized. Because you can see here that it is 22 millimeter oval ventricular rupture post MI. And when you see on the RV side, you can see that the tissues are caught in between, and this is almost very big. And this is the subpulmonic VSD. Never allow the subpulmonic VSD go into PH and PR, because subpulmonic VSDs will never close, and they have to be closed surgically, and closing with the device is not possible. And as a result, Garbuda is the another defect which I have closed with the device. And here an echocardiographer should remember that the type B Garbuda shunt goes through the tricuspid valve. And as a result, it appears like the TR. And if you make it as a TR, you miss the Garbuda shunt. And hence, you have to do well. And this is the patient with the device. And this I have published in the catheterization cardiovascular intervention. And here, the case profile, 16 years old patient, post surgical closure, patch is there. And here you can see that there are two jets coming. One is the residual VSD going into the RV side. Other one is the AR. And this is not suitable for the device closure. And you can see that the adynamic patch and the dynamic interventricular septum. And this is the 3 years after the surgery, the patient has come, and the echo showed that there were 3 residual Swiss cheese like VSTs. And here we closed it with the large device. And after that, only 4 millimeter VST was left, and that was hemodynamically insignificant, and the peer pressure came down. This is the dextrocardia with the VST, mid-muscular VST, closed with the ADO2. And this is how we know we can close any VST. This is the post-surgical, again Swiss cheese, with the multiple ADO2, I have closed that to get the good result. And this was a lady when she was 12 years old. She already had a hypertension, pulmonary hypertension. I fenestrated and put the device. And afterwards, when she's 22 years, now her peer pressure is only 45. She's ready to get married and have the children. Had I left her, she would have died like Madhubala, a beautiful actress whom we lost. And look at this, a huge 24 millimeter VST with the fenestration. I have got the excellent result. Echo is so important that at this time when I was doing this case, the echo machine was taken, and look at what has happened. The patient went into emergency bradycardia, hypertension, and then the device was caught in the tricuspid chordae, and then there was a TSTR. And then look what happened. The surgeon was not ready, OR was not ready, and then they were not ready to take up the case. And I did what impossible can be done. It just with the balloon inflated, I pushed it like, lifting with the crane, and it fell back into the place, and then patient is normal. And here you can see that there is a septal leaflet is wobbling between the two, and this is not suitable for the device closure, because this tissue will be caught in between the two discs, and that will be a problem. See, this is the 3 years old patient with VST PS, and then VST measured on 2D echo as 4.6. And I did the balloon dilatation, and the LV angio showed no VST. I was surprised what has happened to the VST. So when I did the 4D echo, you can see that during the systole, literally the VST is closing. So this is because when there is a contraction, that is closing. And that's how we know it was hardly 2.4 millimeter. So friends, echo is very, very user-friendly. Echo is required before and after the procedure, even for the follow-up. And so much so that if you use the echo properly, you will not be distracted in the cath lab and get into a crash like this. And this is how, a crash can occur when you are distracted. Hence, to get the excellent result and see that you do the best, and the best thing is to use the echo, assess yourself. However good you are an interventionalist, you must see that you evaluate yourself and make the decision. And that's how your success rate increases. That is Kurt Amplarts, who has given excellent devices for us. Thank you very much for your kind and the patient hearing. Thank you.